Welcome to the Vet Dental Show. I'm Brett Beckman, board certified veterinary dentist, and we bring this podcast to you every Wednesday as a veterinarian, as a technician, as a dentistry team to help you be even better at veterinary dentistry in your practice. We're sponsored and partnered today with the Veterinary Dental Practitioner Program. If you're interested in being among the best anywhere in general practice as a team in veterinary dentistry, I invite you to request an invitation. Let's go to ivdi.org/INV, like invitation, first three letters INV. So IVDI, International Veterinary Dentistry Institute, ivdi.org/INV, and we'll get you the information that you need. Heather, how brittle are those hypoplastic teeth? We saw those changes in this case where we've got disruption of the normal enamel. The enamel, in many cases, is decreased in its calcification level. It comes off of the tooth when we clean, which is part of the treatment. And in that, they are more brittle, and they can be super brittle where there is trauma to those teeth from other things like chewing bones before we see them, especially in a young patient, and they fracture. So the pulp cavity in young patients, if you've been with us for a while and you're through 12 of these cases in the case workshop, you know that indeed there are circumstances where you have a young patient and you have this where you look at the x-ray and the x-ray evidence of the pulp cavity diameter is huge. And that occurs with young patients in any respect. But if you look at that radiograph, you notice how thin that dentin is around the pulp cavity, which extends into the crown. So if you compromise it with the decrease in enamel calcification, decrease in enamel quantity, then you're down to dentin or deeper, and that makes that tooth very susceptible to fracture. And add to that a young patient chewing bones, and then you've got a scenario for potential fracture of that tooth. So that does happen, and they are brittle, if you use that term, Heather. They are. I don't know that they're more brittle per se, as far as that term goes, but that's a good way to describe them. But they are more prone to fracture because the calcification component of that enamel is missing or compromised, and so they're not as hard. The teeth are softer because you're down to dentin. They're more likely to be disrupted from fracture. Allison Marie, during extraction, is it common to have these teeth fracture? I assume they're friable. Are there special types of tools for the extractions? And a similar question, but the more specific part of that, is it common to have the teeth fracture when you extract them? And the crown might, which is not a big deal. We don't really have a lot of opportunity to extract these because we can restore a lot of them. Many of them that come to us are not compromised yet. We get them less than a year of age. We do the restorations. We do the treatment, which you have seen in the workshop and see how we do that. And we've described that, so we won't go into that here, but you've seen how we approach those. And we get them young, ideally. We come back and we re-radiograph. And so that's when we tell if we need to extract. And very commonly, we don't run into that because we get them in time and the pulp is still viable. Haley Arola, I believe is how to pronounce your last name. Is there a post x-ray of this, and how much viable bone was touched during removal of the non-viable tooth, I assume? I put some arrows on that image. Let me switch over to the keynote here. I put some arrows on the image. I don't have, we've got a pre or a post-op. We don't have one that I could put my finger on. They're in our records, but based on your question, you can see above that white arrow to the right that there's still that root, that distal root of that, or that root of that tooth that has been compromised from hypoplasia and some probably dens invaginatus or tooth dens dentae, where the crown's been folded on itself as part of the process. And then you've got that area that we pointed to with a blue arrow, that's necrosis or osteomyelitis or both. And then when you look at the area of contour, which was a question, how do we clean that up? Do we have a post-op? How do we clean that? The extent of that right, middle, and left arrow apically is where we essentially would have cleaned that up and removed bone and made that just a nice smooth area that has bone adjacent to that tooth to the right, the premolar to the right, and has bone caudal to it. And so that cup will fill with bone and be replaced within 4 to 6 weeks after we remove the disease bone and leave that defect there, that cup of a defect. It's got walls there, so it will form, we can form a blood clot in there, suture back, and you will get that luxury of having bone form back in that defect. So what nutritional deficiency can cause enamel defects? And nutritional deficiency in general could definitely cause enamel changes. There are no specific nutrients that we would place in that category that we can put our finger on, but any kind of nutritional deficiency would compromise developmental growth of many different things in the body, including formation of the enamel, which happens again at generally from birth to about 8 weeks of age, that enamel is forming. And that's when we get that enamel hypoplasia that's generalized. If it's a traumatic hypoplasia or what we call a regional, not diffuse involvement of teeth, then that can happen up to 12 weeks of age or so, maybe as much as 16, but generally between birth and 12 weeks of age is when we expect to see that. So looking at that from a deficiency standpoint, anything nutritionally that you see in that time frame of 0 to 8 weeks specifically could cause some changes and result in enamel defects or hypoplasia. Kathleen, in this case, similar to what we would expect to see with in utero distemper viral infection, is this associated with fever in the mother that results in the defect. And generally, the distemper is in the dog itself. It's not necessarily in utero. It's in the dog itself when the enamel's forming after the mother gives birth to it. Other defects, if the mother had enamel problems with epitheliotropic viruses like canine distemper, would produce anything that's epithelial, skin, mucous membranes, anything that falls into that category is at fair game with in utero infection. But the majority of these we can attribute to some rise in body temperature, some inflammatory process that causes a rise in body temperature, kills the ameloblasts that produce the enamel, or the odontoblasts that produce the dentin at birth to that 8-week period. So the distemper happens, or the rise in temperature, or the epitheliotropic virus, more specifically in cases of distemper, cause this. Now, we, as practitioners long ago, when distemper was a thing, we saw it a lot in unvaccinated dogs. This happened a lot. But now, with the fact that we've got education for clients, we've got veterinarians that know that and have for years known that distemper is a problem, vaccinated against it, we just don't see this very often. And if we do, Patient's probably been vaccinated and probably has not had distemper. The histories are pretty significant that they've been vaccinated. There's a good chance that the problem is not necessarily distemper unless it happened shortly before these guys were born from an enamel standpoint. Otherwise, they have other defects that I lost my train of thought there. But if we have any rise in temperature during that formation of enamel, those are the culprits, and that usually goes undetected. I think that was another question that we had. When does this happen, and when do clients see when the insult happens, are the patients sick? Usually they're not, and especially for the focal hypoplasia where it's trauma from littermates, you're not going to see that. They're not going to know why or when that happened. So hopefully I didn't get off on too many tangents there. And there's another similar question. How long does it take a fever? I don't know the answer to that. I don't think anybody knows the answer to that for them to have hypoplasia to occur. And actually, when I'm thinking about that question now, I do remember seeing something recently where it was in humans thought to be maybe even a couple of days of fever, but I'm not sure on that. And I don't think anybody knows, especially for dogs or cats. And this does occur in cats too, and can. Has a question: how feasible is this for the general practitioner to correct, or is it always a referral? If you're not doing composite restorations and are really familiar with that, then it's not something that you want to do. Way too time consuming. I generally don't do these in one go. If this is a generalized enamel hypoplasia, then many times I'm going to do these in 2 sessions because it's a couple hours worth of very tedious work. And 4 hours is a lot of time to spend doing this. So it's something where you get fatigued, and it's better not to do it if it's like that. I can do extractions for 3 hours, but I can do this for 3 hours. But if I get into extractions for a couple hours and I've got a couple hours left, that means it's a super hard case to take 2 hours to not finish. I'm going to do it at another time. Super hard is brachycephalic with cups. That's going to take 2 hours per side, 2.5 hours per side, something like that. If a client, Kevin Kirk, if a client will not do restorations, it's best to monitor them radiographically or extract. Yes, Kevin, monitor radiographically. I would say monitor these. If you get them young, monitor them in 6 months. Again, at 12 months, 18 months, somewhere in that range. And Cindy, do these dogs show any increased sensitivity or oral pain? Usually they don't, but sometimes they do, where they're reluctant to eat, and they do show signs where they're uncomfortable, but they're probably not going to show it. And so that increased sensitivity is subjective based on the owner's observation of that patient, and that's not always accurate. But they do have sensitivity. I guarantee you they do, because we can palpate these, or we can take take our fingernail and run across, or even touch them. I had one that I touched that had this problem, and that touch itself induced a pain response, an aversion response of the patient recently. So they do feel discomfort even though they don't have it, because it's just like us. If we have dentin exposure from a cavity, or we fracture a tooth and that dentin's exposed, we can feel cold. We can feel heat and or cold or movement across it. And so these guys, they're not unlike us. They have the same nerve innervation to their teeth as we do. So they're going to feel it as well. Good question, Cindy. I hope that is an answer that you're able to accept on that. Marjorie, are there any other drugs other than tetracycline that cause enamel hypoplasia? And if they receive these drugs after 12 weeks, is it less likely to affect the enamel? Yes and yes. The recommendation for tetracycline administration or tetracycline-like compounds like doxycycline would be don't administer in puppies that are, in mothers or puppies that are nursing 6 months or less. So if the puppies are nursing, and that's just a general guideline so people can use that, it's not specific, But if you have puppies that are still nursing, the mother should not have tetracycline, because 6 months or less is what they say. It's more of then a blood thing where the tetracycline gets into the tooth root to innervate the pulp from the blood supply and discolors the tooth in the 6 months or less thing. But it depends on when the mother stops nursing. But in puppies, for sure, 6 months or less, and maybe even longer to avoid that. But 6 months is a good guideline to go by to avoid that from a tetracycline standpoint. Fluoride is the other component. Fluorosis is another component. So fluoride ingestion would be a situation where that's the case, but that's not something that's common. Tetracycline would be fairly common in some cases. Hope that answers your question. And another question very similar. Ann Lee Suma. I occasionally have patients with individual stained teeth and I can't get the stain out of. So that's one question. And there are a lot of situations where you're not going to be able to get the stain out of, not just from the actual imbrication of porphyrins from the saliva into the diseased dentin or enamel, unless the enamel is removed or it is diseased visibly, and you can go down and remove some of it and it takes it off, that's fine. But if it goes deep, you don't want to really remove it. If it's getting to more of a tooth structure that's normal tooth structure, or you can just have staining from other things that's intrinsic in the enamel that is from a less than ideal surface that's maybe a little porous, but doesn't have defects in the enamel that you can't remove. Wear is a good example of that. Chronic wear can produce changes in the enamel character and color, but you can't remove that. Look at cage chewers. Those are maybe an exception because that's more of an acute thing. And that back part of that tooth, you can remove it, but you have to go down into the enamel a little bit with a diamond football burr or an aluminum oxide or white stone burr to get down in there to remove that. And we generally don't recommend that in general practice. The stain, if it's to answer it clinically, if you have a case where you have staining of enamel, if you are cleaning and you can't get that stain out, it's probably not something you want to address. Probably something that's going to be an intrinsic staining that if you try to remove it, you're going to be causing harm. Intrinsic staining in what otherwise looks like normal enamel is not something that you even want to approach clinically. And from a sealant application standpoint, go back to and watch this case. We talk about that. We talk about dentin exposure, and we talk about when we use sealants for this and how we approach it. So I'll defer that to anyone who has that question, in addition to Ann Lee, about sealants. Refer back to that case, and we discussed that during the case. And yes, Amy, we talked about that just in passing. Amy Sneed, can hypoplasia occur in kittens that has severe systemic disease? And in 2 to 12 weeks or more, birth to 12 weeks would be more accurate. I know we said 2 to 12 weeks, but we feel it's now birth to 12 weeks. And Stephanie asked, how commonly do we see that? Can it affect cats too? Yes, it can. We don't see it real often. And I don't know if that's because it's not detected, if it's not being referred. We see maybe a case every week, and we might do 40 cases a week or more. So a case a week, not real common for us on a referral basis. We see of those, let's say 40 cases, 30 of those are perio, 25 of those are perio, even on a referral basis, to put it in perspective. Wendy asked a question, and we've got 2 more questions that'll put us at the end of this. We're going over a little bit, guys, and I'm sorry about that. But for those of you who are still here, we've got 2 more questions, and then we'll conclude here a little bit late because of my air conditioning episode. Do products like Healthy Mouth help? They help in cases where, as Wendy asked, if they decline treatment, probably more than you would know. They decrease the bacterial colonization, the inflammation, and certainly would help in theory for decreasing the chance of that dentin to be compromised before we can possibly get tertiary dentin formation in those defects, which can occur and sometimes does in these, as evidenced by the fact that we see these sometimes down the road and they're okay. Brushing obviously is the best, but things like Healthy Mouth, Orvet Chews, things that are VOHC approved can certainly help from a plaque standpoint. Any of those things on vohc.org can help with that in theory. Mark, a little bit more advanced question, and I'll answer this for you and for those who are doing composites that have had training, because it's a quick answer. I use Fluid ALC as a composite, which is from Pentron, and ALC means accelerated light cure. And what that means is that it can be cured with your light in 5 seconds. And it's a huge time saver versus the 20 seconds or more that some of the older generations and even some of the newer generation composites require. So the accelerated light cure allows that to happen. And we do, to answer your question further, we do 1 millimeter increments. 2 millimeters is max, 1 millimeter increments in layers, light cure for 5 seconds, and additional layers. And Heather, for the last question in this case and the last question for the day, are there other treatment options for clients who can't afford a specialist? And cleaning really well, polishing these teeth on a regular basis, home care like we've discussed, all those things may allow for time to allow for tertiary dentin formation by the body, which is probably a couple months or weeks to happen. And then once that happens, then you get sealing. And as long as there's not bacteria sealed within that, then we may be okay. Yes, those are options. And follow them radiographically down the road, 18 months at the longest. And if there are changes that suggest those teeth are dead, extract. So that's the way to approach those. I hope you enjoyed that episode. If you'd like more information about the Veterinary Dental Practitioners Program, please submit to request an invitation at ivdi.org/INV.